2-year-old male. She's complaining today, chest pain.
Welcome back to the protocol video series. Today we're talking about S-139, treatment protocol for your trauma patient. BLS, ensure patent airway, protecting C-spines. We'll have our patient be held with manual inline stabilization until we can assess their PMS and determine if they need a collar. Control obvious bleeding, direct pressure right off the bat. If that doesn't control it, we'll use either tourniquet or combat gauze if appropriate. Spinal stabilization as needed, except in penetrating trauma without neurological deficits. O2 saturation as needed. O2 and or ventilate as needed. Keep warm. Remember your treat for shock protocol. And then hemostatic gauze as needed. We're going to jump back here to spinal stabilization, except in the penetrating trauma without neurological deficits. Neurological deficits are evaluated by checking pulse, motor, and sensation in each of the extremities. Abdominal trauma, we should cover the eviscerated bowel with saline pads. So we'll take our abdominal pads out of the packaging and soak them with sterile saline. Chest trauma, cover the open chest wound with a 3-sided occlusive dressing. Release if questionable, that's what the question mark stands for, if questionable tension pneumothorax develops. Use of a chest seal. So instead of a 3-sided occlusive dressing, we can also use a chest seal. As you saw in our videos, we use the hyphen chest seal most often. Extremity trauma, splint neurologically stable fractures as they lie. Use a traction splint as indicated. Remember, those are for mid-shaft femur fractures only with no other involvement of the hip, the knee, tib, fib, or ankle. Grossly angulated long bone fractures with neurovascular compromise may be reduced with gentle unilateral traction for splinting per base hospital order. We do not reduce fractures on standing order. It is base hospital order only. Apply a tourniquet in severely injured extremity when direct pressure or pressure dressing fails to control life-threatening hemorrhage. In mass casualty, direct pressure not required prior to tourniquet application. Impaled objects. Immobilize and leave impaled objects in place. We remove only per base hospital physician order. The one exception is that we may remove an impaled object in the face, cheek, or from neck if there is a total airway obstruction. Notice the wording here, total airway obstruction. Neurological trauma, so we're talking about our head and spinal injuries. Ensure adequate oxygenation without hyperventilating with a goal of 6 to 8 ventilations per minute. So those are for your neurologic trauma patients. We have a goal of 6 to 8 ventilations a minute, not 10 to 12. Pregnancy of greater than or equal to 6 months, where spinal stabilization precaution is indicated, we tilt the spine board 30 degrees. Now that's 30 degrees laterally, not vertically. Blunt traumatic arrest, we consider pronouncement at scene per base hospital physician order. It's always a good idea just to get ALS involved if you are on scene of a blunt traumatic arrest and ALS is not there already. And we'll reference S-402, pre-hospital determination of death, for further information. Flipping over to the next page. Some important information, some pertinent information that we need to be familiar with. Routine disposition pediatric patients who meet criteria outlined in the T460 identification of the pediatric trauma center candidate should be delivered to the designated pediatric trauma center, except in the following situations. FYI, pediatric trauma center is Rady's Children's. If there's an adult and a child, if there is a single ambulance, either air or ground, with both pediatric trauma center candidate and an adult center candidate, the ambulance should deliver the more critical patient to the appropriate facility. If both patients are critical, or if there are other questions, both may be delivered to the designated adult trauma center. Field personnel should consider splitting the team and using additional ALS transport vehicles or aeromedical resources to transport the pediatric patient to the pediatric trauma facility and the adult to the catchment area trauma facility. Bypass or diversion. If the designated pediatric trauma center is on bypass, pediatric candidates should be delivered to UCSD. Less than 15-year-old pregnant patient should be delivered to the University of California, San Diego Hospital. All right, so these are some transport guidelines. And remember, guys, as EMTs, oftentimes the people who are responsible for the transport, obviously the decision is made by ALS, but those who are ultimately transporting these people, as in where are you going, where are you driving, that is oftentimes an EMT. So do you need to know these protocols? The answer is yes, you need to know them. So this is your trauma protocol S-139. Thank you guys for watching this video, and we will see you on the next one.